Today it's the second foundation day of HEAL. HEAL is Health Equity Action Learning Foundations, which is registered as an NPO company at Chandigarh. So the primary objective of the HEAL Foundation is to work on health equity. And on the second foundation day, we have a webinar. And the speakers of the webinar are Dr. P.K. Shashidharan. So he is an alumnus of Postgraduate Institute of Medical Education and Research, Chandigarh, and serves also the former professor and head of the Department of Internal Medicine at Government Medical College, Calicut, Kerala, and was also the head of the Department of Hematology Department at Government Medical College, Calicut, Kerala. So he has a clinical experience of more than 35 years into the internal medicine and teaching. So welcome, sir. Welcome you to the second foundation day of HEAL. And we'll start the session with Dr. Shashidharan, sir. The second speaker is Dr. Rajesh Kumar. So he's supposed to join from Australia. And because of some technical issue regarding the IST and Australian Standard Time, he's not able to join right now. So in case if there is a technical difficulty, I request all the participants, a separate link will be sent in the chat box so as to join with Dr. Rajesh after Dr. Shashidharan's initial talk. So I welcome Dr. P.K. Shashidharan to enlighten us on his clinical perspective on health equity. Welcome, sir, and the floor is yours.
Thank you, Dr. Vineet. I'm delighted to be here to talk on a subject which is so dear to me. Can you see my screen?
Yes, sir.
Hello.
Yes, sir.
Yes,
Okay.
sir.
So the topic that we are discussing is health equity, and obviously it is an issue of public health in India. Issues, challenges, and way forward is what I would like to discuss with this audience. Health equity is an absence of avoidable, remediable, unfair differences among groups of people, because health is a fundamental human right. The groups can be defined socially, economically, demographically, geographically, or by other dimensions of inequality, including gender, ethnicity, disability, or even sexual orientation and practices. The issues and challenges that we face are discussed only if you look at why people get diseases. I'll just summarize the problems that finally lead to diseases. Or most important of which is multiple causes. I don't know, somehow I am getting echo. Hello, now it is all right. Because of several reasons, majority of our people have one or other kind of malnutrition. That's the most important issue. This is the primary cause for several diseases. Then you have these problems which I have highlighted here, and one or more problems together finally make a person a patient. At that point only they get admitted to hospitals where we focus only on giving medicines or resecting organ, repairing or bypass or replace at enormous cost. But we all forget the basic issues behind the diseases. That has
എല്ലാ തെളിവുകളും ഈ കേസിന് വേണ്ടി ശേഖരിച്ചിരുന്നു. ഈ പ്രതി ചേർക്കപ്പെട്ടിരുന്ന അർജുനന്റെ ബീജം ഉൾപ്പെടെ ഹാജരാക്കുകയും ചെയ്തിരുന്നു എന്ന് പറഞ്ഞു. സാമ്പിൾ ഇല്ലായിരുന്നു എന്നുള്ളത് പോരായ്മയും
iPhone 14 Pro Max, please mute yourself.
പരിശോധന കൃത്യമായി നടത്താൻ സാധിച്ചിട്ടില്ല. എന്നാൽ ശാസ്ത്രീയമായിട്ട് തെളിവുകളെല്ലാം
please mute all the participants except the speaker.
സാഹചര്യമുണ്ടായില്ല. ഒപ്പം മറ്റ് തെളിവുകളും ഡോക്യുമെന്റ്.
Okay, in summary, these are the causes for all diseases, but unfortunately, the focus is only here after they become patients. We forget all these issues. And the number one problem by any count is malnutrition. Even obese people are malnourished. We had a survey and we found that 98.5% did not even know what a proper diet is. Even if they know, they may not be empowered to eat it properly. When we talk about malnutrition, we think only of this extreme malnutrition. But even rich people have malnutrition. That's a point we need to keep in mind. Second is poor waste disposal habits and absence of waste management. This is still prevailing everywhere. Third is we do not have safe drinking water in the public distribution system. We still depend on boiled water or filtered water or this plastic bottle filled water. And the fourth is unchecked consumerism promoted by our celebrities, film stars and cricket stars. They compel people to buy one or other unwanted things and waste their money and buy diseases. That's what is happening everywhere. This is not a problem of India alone, it is happening all over. Due to the unchecked consumerism, overeating has become the order of the day, and there is an obesity epidemic all over the world. India suffers more seriously because people are more seriously having undernutrition and some malnutrition issues. Alcohol consumption is increasing. Fast food has replaced normal diet. Lack of exercise. People prefer sedentary work only. Smoking is increasing in the female population. Unmanaged stress is on the increase. So in India, especially, the issue of malnutrition is serious. And on top of that, same people who are having malnutrition are exposed to consumerism too. And this together, the people who do not eat a balanced diet are exposed to all these bad habits. And finally, you have several diseases as a package. This is what we witness in India especially, but it's a problem all over the world. But primarily because of this deadly combination, we suffer from heavy burden of diseases. And finally, India has become number one due to this double burden, that is infections on one side and non-communicable diseases on the other side. We still have starving population, underfed malnutrition, and all these unwanted trends, which is increasing every day. Once we forget that diseases occur among the marginalized sections. Marginalization does not mean always poverty. You may not be aware of what is needed for healthy living, or you may not be getting all the items needed for a healthy living, or lack of empowerment and awareness on health needs itself is a marginalization. And hospitals should be accessible to all the marginalized sections with equal opportunities and service, and no one should be denied treatment. Then only we can say there is health equity. Public health is making available all the health needs and the determinants of health to all, irrespective of caste, color, or creed. And we have been neglecting basic health needs for several decades, even after independence. And we are now having double burden of diseases with the highest disease burden in the world. If you look at the health problems across, please mute others. If you look at health problems across the globe, these four are the major health problems. All these four are active in India. We have not solved any of them. But the developed world has, please mute others. The developed world has solved first three.
चार एक और कॉपी आनी चाहिए.
Please mute others. So these three are solved in most of the developed countries, and their only problem is the last one. So India is suffering from all these four problems, still remaining very active. We haven't done much about it. This is a problem of the developed world: overeating, decreased physical activity, alcohol consumption, smoking, unchecked consumerism, and bad lifestyle. But this is very much there in India too, in the same proportion as we see in developed countries. But the impact of this is much more serious due to the prevailing malnutrition in India. And then if you look at absence of equity in disease care, there's no universal insurance coverage. Out-of-pocket expenditure is the rule here. And private establishments in treatment are more than government hospitals now. It is in fact growing because we are following the USA model of disease care. So finally, we have ended up with an inverted pyramid of disease care, and this is a major problem that we are suffering from. Genuine healthcare or the social determinants of health or the health needs are missing to majority of the people, and that is why we have a huge burden of diseases. And then to tackle this huge burden of diseases, we do not have good trained, competent, and confident primary care doctors, called as family doctors or GPs, sitting in the periphery or sitting in the PHCs, and they are also missing. Even general hospitals are now getting converted to super specialty hospitals and high-tech treatment centers. And this inverted pyramid is one of the major reasons for lack of equity in disease care in India. So equity in disease care is a striking problem here, and we can think lack of equity in disease care is a striking problem, and equity is possible only when all would get same opportunities for treatment of their diseases, which has already been achieved in most of the developed countries, especially the Scandinavian countries, including UK and Australia. What is the way forward to achieve equity in healthcare and disease care? We need, first of all, to reduce the disease burden as a priority to make disease care sustainable. With a huge burden of diseases, whatever may be the machineries that we establish to treat diseases will not be sustainable. It will collapse, and it is collapsing. So we need to, first of all, reduce the disease burden, and then only a disease care machinery itself can sustain. We haven't done anything to reduce the disease burden in India so far. How to reduce the disease burden? Let us provide these social determinants of health to our health needs to everyone. These are the social determinants of health. Provide safe drinking water to all. People should not be boiling their water, filtering their water, or drinking unsafe water. Good primary education is very important. Basic need to promote healthy living, because that will instill humanness. Please. Good primary education will instill humanness and concern for the fellow human beings. That itself is the beginning. That itself will be the beginning of health care in India. Good primary health care with trained family doctors is the third one, and decentralized integrated farming to make available all the components of a balanced diet, and then environmental health, provision for exercise like public places, footpaths, cycle paths, rather than setting up health clubs and yoga centers. Good sanitation facilities, and the political system has to be empowering people for health needs and good lifestyle, because politics is intimately linked to health systems and healthcare. We need to promote proper waste disposal habits among each individual, and we have to provide good waste management in the society. And good lifestyle has to be taught in schools and colleges, and these are the good lifestyle habits, and each one of them needs emphasis. And the primary care doctors or the primary health centers or family health centers can do a lot in educating people on these good lifestyle habits. It is not possible to educate people on good lifestyle through corporate hospitals or tertiary care centers or medical colleges. They need trained, motivated, competent primary care doctors or the family doctors to educate people on good lifestyle habits. I will not elaborate on these good lifestyle habits. It has to be taught in schools and colleges. It should be part of school health programs, and every patient attending a primary health center should be educated on these things. That's at most importance to reduce disease burden. And we always read about happiness index, and the miserable place. India is 140th place among 156 countries. We can say it is due to the wrong ranking, but it's not so. India's position in happiness index is very, very poor. It is all due to these basic issues which I have been discussing. There's no point closing our eyes on that issue. Rather than running away from it, we should face it and as a challenge, and we should do something to correct all these. Wellness or happiness is an issue of social security and human development. It should not be just reduced to medicines and treatment, even if it, because we focus only on either modern treatment or indigenous treatment. we forget all the social health. Social health has actually become a neglected orphan in India. The truth is, we cannot achieve health. We cannot achieve health in compartments, either in an individual or in a society. Social health will indirectly nurture individual health. So the focus should be on social health. Now we're coming to a major issue, why there is no social health care in India, why there is inequity. This has to touch upon basics of health economics. We do not have enough resources to provide social health. Social health care or providing social determinants of health to each individual in every part of the country is essential to reduce the disease burden. We say that we do not have enough resources, and that is why the resources are less. I will discuss next, and whatever available resources we are wasting also. These two aspects I will cover as an issue of health equity, lack of health equity. Why the resources are less? Because of lack of social security, people become money minded. We are from childhood onwards, we are grown up in a society which is money minded, and every child is growing up with a money making attitude. And slowly, when they start making money, they unknowingly accept these corrupt practices, and then they start making money. They succeed. Some of them succeed. They start accumulating all the wealth, and mostly as black money, and then make dead investments in land, gold, and huge houses, or even in foreign banks. And this money is not available for social security and human development in the country. And this leads to lack of equitable distribution of wealth. The richest people in the world, 10% are actually Indians. But they store enough money as black money in several places. Whatever resources we have is wasted also. The limited resources we have is wasted because we have been ignoring health needs. The priority goes to treatment of diseases. By ignoring healthcare, on one side, we are manufacturing diseases. And then for treatment, we are setting up only high-tech facilities, state-of-the-art facility, and even the basic facilities, including family doctors, are neglected. Even general hospitals are neglected. Over-treatment and over-investigation in the high-tech facility is the rule now. This is all because we are following the Americanized disease care model, which is the worst model in the developed world. The worst model in the developed world is American model, and India, unfortunately, is following only that. That's the biggest problem that we face. And we have several vertical programs in the name of every disease you can mention. National Malaria Eradication, Filariasis Control, AIDS Control, TB Control, NCD Control, National Anemia Control, Anemia Mukt Bharat. It goes like that. I can enumerate so many such vertical programs. All these are standalone programs. They do not even meet each other, discuss each other. Finally, all the resources are wasted on these vertical programs. All these can be brought into one if you had a strong primary healthcare with a large number of trained primary care doctors sitting in PHCs. And then we could have actually united all these vertical programs. And there is no effective nutrition programs or drinking water programs or waste management programs or environment programs or lifestyle intervention programs using family doctors. There's no strong health policy also. This is the reason for lack of equity in healthcare in India. We should learn to copy only the good things from others. We should learn from the mistakes of other countries rather than copying their mistakes and copying all their bad things. That is, we do not copy the good things, even if it is a country which we do not like. If there is anything good, we have to copy it. That should be our attitude. Okay, look at these to promote exercise. The Scandinavian countries promote cycling. They have cycle path on all their roads, and cycle is given the prime parking area in front of all the buildings. Cars are not allowed here. This is a main railway station in Copenhagen and Denmark. So this kind of approach to all the social issues is very important in promoting healthy living and happiness. So therefore, what any country should do is we should work for social change. We should control poverty and malnutrition, promote good diet and lifestyle. We should provide clean surroundings, safe drinking water, and we should promote genuine healthcare through trained primary care doctors. And to achieve that, all ministers must know what is their role in providing healthcare. Every minister has a role in providing healthcare. And we should finally work for a social change, focusing on good primary education to convert each child into good human beings. Good primary healthcare using large number of trained family doctors. Decentralized integrated farming should be promoted to provide all the requirements for providing a balanced diet. We need economic reforms, reduce rich-poor divide. And finally, with the resources raised, we can provide good social security and human development. And this money-mindedness or money-making attitude of the people can be changed. India is a rich country. Don't think India is poor country. We have enough potential and resources. Human resources are the best in the world. Weather is the most optimum. Naturally beautiful, God's own country. And we can probably think that we are in the process of moving forward. But I don't think it is going in the right direction because we are imitating USA. People talk about India progressing, but it's not in the right direction because we are imitating USA only. That's where the problem is. We have enough resources. What we need is a strong health pyramid. Every individual should have access to basic health needs. And then the most important doctors should be trained family doctors or primary doctors, as in all the developed countries. Even the USA has 40% doctors, though everything is in private. It's a worst system, but still they have a large number of trained primary care doctors called family doctors. 40% of them are primary care doctors. And then we need to promote general hospitals rather than specialty hospitals. We focus only on these last two. That is our area where we are failing. And I am just trying to tell that we have the potential. This our Air Force building India in the sky. People sitting on the ground like us also have that similar potential. We need to do our share of work to take India forward. When you say sound mind in a sound body, sound human beings are possible only in a sound or a healthy society. Because public health is all about public health and social health mean the same thing. We need to promote public health with all possible means. Because right now, public health or social health is a neglected orphan in this country because we do not focus on public health basically. We focus only on individual health too with hospitals and indigenous medicines. The issues which I have discussed are covered in these two books. Those who are interested can buy these and read to get more insight into what I have been discussing. Thank you for the patient hearing. I can take any questions if there are any, or after Dr. Rajesh, if he has joined present. I hope Dr. Rajesh has joined.
Thank you all. Thank you, Dr. Shashidharan. So I hand over the floor to Dr. Manmeet Kaur to moderate the further sessions. Dr. Manmeet.
Thank you. So just to begin with, I would like to say that health is a thread that binds us all, yet not that everyone has equal access to the avenues for good health. And that's why we are actually exploring the concept of health equity. And you have already heard Dr. Shashidharan, and you must have realized that we are aiming to bridge the gaps that persist and create a more inclusive healthcare landscape. So I will not take much time and would like to introduce and invite Dr. Rajesh Kumar, former Dean, PGIME at Chandigarh, and HOD of Department of Community Medicine and School of Public Health. Presently, he is Director, HEAL Foundation, and he has more than 470 publications and H-index of 72. His commitment to have a just world where everyone has equal rights to enjoy good health will be reflected through his talk. He will talk about how health equity goes beyond equal healthcare access, something which Dr. Shashidharan has just talked about. He will be trying to go beyond that. So over to you, Dr. Rajesh. Please start with your presentation. I hope it's ready.
Yeah, thank you very much for your nice, kind introduction. I will be speaking on health equity and primarily the the basic concepts of related to health equity. I am trying to share my screen.
So I suppose that there are some questions. If those can be shared with me.
Is my screen visible?
Yes, sir. Yes, sir.
Is my screen visible?
Yes, sir. It is visible.
Okay. So can I start?
Yes, please.
Okay. So in this presentation, in about 20 minutes, I will be covering some aspects of the historical roots of health equity, and then trying to define what is health equity and what is the health inequity landscape in India, what are the causes of health inequity, and then how to monitor it and address it. And finally, I will be summarizing my thoughts. So, as you know, human societies have evolved from, hunter-gatherer to present time. And many scholars, they have categorized these into 5 stages. And in each of these stages, some humans had taken care of the sickness of others, whom we call physicians. But these societies have changed from earlier period of when there was hunting gathering. They passed through this phase of agriculture, and then to the industrial societies. And in fact, it was in the industrial society that these concerns for equality and equity, they came to the fore. Actually, before this era, the societies, they generally uh, got organized, which we call civilizations, from villages to cities, when predominant mode of production was, agriculture, and where, there were landlords, princes, and on the other hand, tenant farmers and sometimes slaves. So that continued for a long time. And with progress of technology, the steam engines, etc., when mass production became possible, lots of people from the agricultural society, they moved to industrial centers. And it is at that time that, the concerns for, the human condition were discussed in much depth. And you know that in the French Revolution, the liberty, fraternity, and equality, these concepts, came to the fore. And now in this century, 21st century, we are, discussing these aspects in detail. And as the society is progressing, we will be discussing, and maybe we will come to know that why we have still so much of inequality and inequity, and how to address it. Uh, so I came across one article by Yao et al. Recently, where he has traced, all the papers published so far. He did a systematic review, and he discovered that, the concerns for equality and equity arose, in the middle of 19th century. And the first one in England, Frederick Engels, wrote a book, a short book on conditions of working class in England, where he showed that how the mortality rates are much higher among the working class compared to the others. And then he tried to discuss why this is so. And around the same time in Germany, Virchow, Rudolf Virchow, he as a young person was sent to investigate a epidemic of typhus in Silesia, Upper Silesia, and then he wrote a report and described the working and living conditions of people there and advocated that, unless these conditions are improved, disease is not going to go away. And then later on, a sociologist, this Durkheim, he also tried to study societies and found out that there are some social factors which lead to suicides. And in America, North America, Du Bois also did a case study of in Philadelphia among Negroes. And this is how, by the turn of the century, this Berkman and Kouachi, they developed this field of social epidemiology. In traditional epidemiology, we discover some causes more so related to biology, which decide the pattern of illness. But then these studies went beyond and tried to see why there is a differential in mortality in the socioeconomic groups. And later on now, Michael Marmot, his seminal paper in Lancet in 2005 on social determinants of health actually summarized all that knowledge into this short paper. And what we see is that, after late 90s, there was more interest in this field of health equity and health equality. And this is growing now because in many countries, even in the industrialized countries, where state welfare is quite advanced and poverty levels are not that high, even after that advancement, the differences in health status, they still remain, and they try to find out why that is so. So there is a growth of a lot of literature in this field. And a particular milestone was this declaration of Universal Declaration of Human Rights in 1948 by UN, where, globally throughout the world, for the first time, it was recognized that humans are equal. They are born free and they are equal in dignity and rights. And they live in a spirit of brotherhood. This is Article 1. So this was for the first time declared at the global level, no more slavery, no more, injustice. And Article 25 of this Universal Declaration specifically declared that everyone has the right to standard living adequate for health and well-being for himself and for his family, including food, clothing, housing, medical care, and necessary social services, and right to security in the event of unemployment, sickness, disability, widowhood, old age, and other lack of livelihoods in circumstances beyond his control. So this laid the foundation. And immediately after formation, the World Health Organization in its constitution also declared this right to health. And they not only said this is, is a fundamental human right, but that governments have a responsibility for health of their peoples, which can be fulfilled only by provision of adequate health and social measures. And now WHO and United Nations, in their sustainable development goals, they have this universal health coverage as a very prominent goal, which says no one left behind. In other words, that health equity is achievable. So we have these declarations at the international level, and following these declarations, WHO also tried to define what is health equity. And according to WHO, this is a public health concept describing equity of access to health resources for genetic, socio-environmental, and economic determinants of health, varying according to individuals, families, and social or societal groups. So not that everybody agrees with the definition, but this is best they came up with, and there can be a scope of improvement in it. But now many scholars, they use this term, health equality, others use health equity, and still others, they use health justice. So what are these, and how they are similar or differ? This is depicted in social media through these um, schematic diagrams. One can try to see equality is when, this is some kids are playing football and others are trying to watch them. The assumption under equality is that everyone benefits from the same support. So everybody has equal support. This is a kind of in our fundamental rights, that everybody has same rights, equal rights. But despite having those equal rights, still, there are some people who are able to, watch the game, and others are not able to watch the game. Still, although there is theoretically equality, but in real practice, we still do not reach equality. So then the second term, equity, it signifies that everybody gets the support they need. Those who need more support, they get more support. Those who don't need support, they are on their own. Even then, they can watch the game. For example, in this picture. So this is the concept of affirmative action, thus producing equity. And then you see, justice is used when everybody can see the game, as in this picture, which means we remove the structural barriers. So you see in the first two pictures, there is a barrier, and in the third, we remove the barrier. So which means that we do some structural level interventions and remove these systematic barriers. So this is how these three terms are being used. In some countries, like particularly in the US, people also use the term like health disparity. And sometimes they mean by health disparity is kind of equal to health equity. So this is how different terminologies are being used, which have slightly different meanings. So one has to be very careful which terminology one is using. Actually, equity and justice would demand a fair share of resources, opportunities, privileges, and power. And here keyword is a fair share. It is not equal share. So according to the need, one has to decide, and fair share, what is the just share. So this is how these terms are differentiated. So one can look at another way. Health inequality, one can refer to the use of data to find differences. So we have differences in different population groups. So we say this is health inequality because there are differences. And health equity, we refer to differences that are unfair or unjust. So it is not that all differences are, unjust or unfair. So therefore, one has to decide on that which one are avoidable, remediable, and these differences which adversely affect socially disadvantaged groups. This is another key term. That there are certain groups, socially disadvantaged groups, their position, social position in the social hierarchy is such that because of that hierarchy, these groups systematically face unfavorable social, economic, and political situations which affect their health. So this is the fine difference between health inequality and health inequity. So one has to keep that in mind. So health inequity is around the world. If you take life expectancy, there are a lot of differences in life expectancy around the globe. In Japan, people enjoy life expectancy of 84 years. In Nigeria, women will have life expectancy of about 54 years. And in India, the government of India sample registration system, they do give life expectancy, but they give it by rural, urban, and by various states and gender. But this was for the first time from NFHS. Data came, the life expectancy by caste groups, and they are by religion and other variables also. And one can see that between scheduled caste and general caste, there is a difference of about 5 years. So one can then try to see that why these differences are there. There are many explanations, many theories and models. And to summarize these, one can say materialistic explanations. Some people have less money, less resources, and Dr. Shashidharan might have given you the presentation of how some people have lack access to water and other things. And then there are other explanations like cultural variations, behavioral variations, and some people say psychological explanations, that those who have low social position or those who are oppressed, marginalized, those populations, they have a lot of psychological social stress, and somehow these stress hormones, they do something to the body. And another explanation is life cycle approach, that some exposures during childhood, early childhood, they carry on to the adult life also. And another explanation is neo-materialist explanation, which is, the welfare state, when they provide something like water supply, sanitation, nutrition. So those are also some of the explanations. There is a book written by Sundari and Rakhal in 2018. It gives a good review of these explanations. And this is one of the framework which Didration gave, and primarily try to have two contexts. One is socio-economic, cultural, and political context. Another one is this health policy context. And in between is the uh, circumstances, and how these social contexts, they lead to social stratification. And in the social stratification, there are people are located along a scale, higher class and lower class, like that, and according to which they have access to these resources. So this is on one end, and how these things will affect intermediate variables, and ultimately the health policy and these variables then lead to, when people are ill, then access, affordability, accessibility, etc., they play their role, and this is how health outcomes get decided. So it's a complex web, but it gives some mechanisms. And one PhD scholar, Anna Sophie, summarized it for her PhD thesis in this diagram. This is the social context and policy context on one side. And then she says this social stratification decides the social position. And according to social position, people have differential exposures, and then they have disease. And the consequences of disease is also different in different social positions, which further exacerbate the social stratification. So this is how social vulnerability and differential consequences, these are social issues. And then one can also identify policy interventions in this. Like initially one can have interventions for decreasing the exposures, decreasing the vulnerability, or preventing the unequal consequences. So this gives a good idea about the, what causes health inequity and how it can be addressed. So monitoring is also important. and the WHO provides a framework which is called Progress Framework. They also have a toolkit. One can use it and monitor health equity. Now in India, there are many surveys. NFHS is one, 5, 6 NFHS have been done. So this is one example how one can see whether inequity is decreasing or increasing. You see by region, caste, and wealth groups, the stunting among children, and you see that stunting is declining everywhere. But if you see the rate of decline is higher in the lower groups as compared to the higher groups. Same is true about caste and rural urban. So one can see that inequity is decreasing over a period of time. This is how the impact of policies can be assessed. So monitoring will help us in understanding that what are the root causes of these inequities, and then one can focus on which programs, which policies are beneficial and which are not yielding good results. And one has to do participatory mixed method research to find out and to conduct this political economy analysis rather than our traditional risk factor based epidemiological analysis. One has to join hands with sociologists to try to find out, that how this system is working. And this data on health inequity can empower civil society and activists, and they can ask for political change. So how to address health inequity? So first thing is that uh, we should find interventions which have better outcomes in the disadvantaged subgroups, as well as, that will lead to overall improvement. And these sometimes these intervention inadvertently, they worsen the situation. For example, mass media campaigns, sometimes the groups who have resources, they are able to utilize those things and others can't. So we have to do the measurement of these inequities and find the solutions and then see what impacts these have. And ultimately, to make the change more sustainable and more lasting, one has to improve the life or living conditions. And unless that is done, distribution of power, money, and resources, one cannot have a lasting impact on disease production. One can keep on doing work on to reduce the consequences of ill health, but to produce health, one has to strike at the root cause. And our constitution provides us that instrument to act. It has the right to equality. There are many articles in our constitution: equality before law, prohibition of discrimination, equality of opportunity, abolition of untouchability, abolition of titles, right to life, which is related to health. So our constitution is a very progressive one, and a lot of articles in the constitution, they provide for equality. And directive principles of state policy also direct all states that they should strive to promote the welfare and justice. Lots of provisions are there. So in summary, I would say health equity is the unjustified difference in different social groups. Health inequity is due to social injustice. One has to understand it. Why social injustice? And maybe we'll have another seminar for it, which means unfair share of resources, opportunities, and privileges or power. And the root causes of health inequities lie within the social structure, which means hierarchies, oppression, exclusion, marginalization, which is shaped by the political ideology. And health equity is achievable. It is avoidable, preventable, and social change is needed not only in material conditions. You provide, free healthcare, water, nutrition, so many things. These change the conditions. But along with changing the conditions, one has to think of how to change the social positions, how to reduce the hierarchies by political action. So that is the ultimate goal, to achieve health equity in society. And I think this is the primary goal of public health, to achieve health equity in the society. So thank you very much for your patient hearing, and I hope you have some questions, although we are running a bit late. Thank you.
Thank you. We will open for question, but before that, I would like to comment that surely that we need communities to play their role in shaping health outcomes, and we also need policy interventions in that prioritize inclusivity and social justice. But I am more for the big movements of change, because unless until we bring social, not social, political and economic changes, things won't change. As you have already mentioned that inequity is increasing. So health, if it is being reflected in health, it means somewhere inequity is increasing in the social life of people. The stratification that we need to address, which we generally don't talk about and don't want to talk about at the same time. But people are now coming up with ideas that how can we bring changes and can address stratification in the societies. So with these words, I would stop here because I think there could be one or two questions. I could not find any question in the chat. If anybody has a pressing question, please raise your hand and ask the question. I completely understand that it's a difficult concept. It's not easy to digest, but at the same time we are open to discussion. It's basically for discussion so that we learn and grow together on the journey of health equity and social justice.
Manmeet, there is a hand of Jobbins.
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 Yeah, please.
Sure, please.
Yes, sir. My question, as I understood, health equity is achieving the health even when there is a presence of any unjust social causes or arrangements. That's what I understood from your class, that we have to still give the help to the people, even if they are suffering from social injustice. But my question is, we have a lot of studies on the social determinants, what are the risk factors, what are the issues. But do we have a study on which is the best intervention in a certain situation, a certain condition of a population? Whether it is cost effective or which process will elevate or reduce their issues. Do we have any studies or do we conduct such studies to analyze which will be the best intervention to reduce the issue?
Yeah, can I answer this?
Sure, please.
Well, I think in the epidemiology, we do, risk factors for various conditions and then do the cost effectiveness also. In fact, many of the social determinants of health, they have impact on many conditions, not one condition. Like water supply, for example, it will prevent so many illnesses. And unfortunately, people are not doing cost effectiveness of these interventions. They do cost effectiveness of, say, for example, individual vaccine or individual drug, and still work is required that if you change a policy, not only for this water supply, but say, for example, if we can change, the social system in favor of that people get more participation in the system, they get more decision making, they are listened to more, and they are provided with resources, and we reduce hierarchies in the system. So those kinds of studies and those kinds of interventions are required actually, and researchers should pay attention to that part. Thank you.
Thank you. Uh, I might add a bit to it. There are studies and there are interventions. Where interventions have been proven quite good, quite cost effective as well. But those are just probably we have seen such studies in the past 10 years, and those are more in line with what Dr. Rajesh just mentioned, that we have to have participation from the people. That will be more sustainable change. That will be more like equitable change. So that's what is the key message, I think, that we all need to carry.
Dr.
Anyone
Khaiwal.
else?
Dr. Khaiwal is there.
Yeah.
Good afternoon, sir, or good evening, ma'am, whatever it is. My query is that we are seeing
Unmute yourself.
Yes, sir, it's done.
You're
Okay,
audible.
sir.
You are audible.
Okay, I'm audible? Yeah.
Yep.
Sir, we are seeing that the social media is influencing us a lot. So how do you see that could bring or means cohesiveness or divide us more? And if yes, then what you feel that we should do in near future so that we achieve social justice and equity for all? Thank you, sir.
See, the social system is not something which one person is influencing, or one person is doing this. It's a trend all over the world. You see, this is a political trend. There are political ideologies. Some ideologies are egalitarian ideologies. Some ideologies, are for solidarity. You see, some ideologies, they are like what you call supremacy. Like racism, for example. White supremacy, for example. You see, so there are ideologies like that. And some people like corporations, big corporations in the world, the kind of system which we have, lots of people are working, not getting fair wages, and the profits are being accumulated at some places. So those who have the power and privileges, they would not let those privileges go away and do not want to share those privileges. So the narrative throughout the world is built through social media, mass media, some kind of consent, so that people themselves, fall into that trap of that divisiveness, as you are saying, in social media, so that nobody questions the basic issue. Why majority of people are not having health services which they should have, whereas everybody is contributing the budget and the tax of the government, but why a fair proportion of that is not being used for welfare? So if people start raising that voice, so this is how attention is diverted through social media, other media, like that. There is one article here in the BMJ recently published by Jason. I have quoted it. He is a climate scientist, economist, Jason. This is capitologenic diseases. Capitologenic diseases. I found it very interesting. So if you can go through that. Thank you.
Thank you. There is another question, and I think that could be the last question. Dr. Sashidharan, would you like to add before I ask that question? We have 1 minute, I think, with us. No, we have overshot.
Dr. Raj Gopal wants to ask a question.
Yes, I have a question for Dr. Sashidharan.
Please.
Sir, health literacy is then it is the ability of the individual to take their own decisions about their own health, that is informed decisions. And Kerala is a state where we have a high literacy rate. And what is your experience? What is the degree of equitable health in Kerala, or is it equitable? If not, what is the degree of disparity? What is your clinical experience regarding Kerala?
I think even in Kerala, the issue of inequitable distribution of resources and all facilities is still existing. If at all there is some improvement, it is due to the distribution of wealth and resources. But otherwise, the information and health is actually focusing on disease care only. Nobody is aware of basic issues like the importance of social health, social determinants of health. That is not being discussed at all. The issue finally focuses only on treatment, that too high-end treatment like transplants and dialysis. That kind of discussion only is going on. Nobody is aware of social aspects. So the awareness in Kerala is a kind of misplaced. I don't think it is in the right direction because there is nobody to educate people. Lack of awareness is the result of lack of good primary education and lack of good primary care doctors who connect well with people. That's a basic issue that we need to address as a practical solution. We need to bring in large number of doctors, scientifically trained doctors who can change the mindset of the people, and that's the only way to move forward.
Thank you. The last question, which is there on the chat box, anyone can take it. It's respected, sir. Can moving health as state subject to concurrent list close gaps related to regional disparities which our country faces in terms of equity?
I think some people feel like that. Okay, but it is not that because of this issue that we are facing the problems. Health is a state subject, you see, because India is so varied, you know, from north to south, east to west. There is so much of variation. One policy, one solution, it is very difficult it can work all over the country. And the central government does some work. They have national health programs for the whole country, and sometimes they are for specific disadvantaged population, just like National Rural Health Mission was only for certain category of states to begin with. So one basic question is whether you want to address inequity, you know, rather than quarreling over this issue, that whether it should be concurrent or state or center. The issue is, adequate allocation of resources for this, and they should come from the center as well as from the states. So rather than diverting ourselves on that technical issue, our focus should be that adequate allocation both from state as well as from center for health. So I would say that.
Thank you.
In fact,
yeah, well said. Can I now invite Dr. Rajgopal to please thank everyone?
Ma'am, before that, Dr. Sashidharan wants to add, I think.
No, I was just trying to mention that
Sorry.
if you want to address inequities, every department, starting from finance, law, agriculture, education, health, all should come together to address inequity rather than just talking about state central division. Health is a state subject only means the state has responsibility to provide social determinants. That can be taken up by the center or state, and every department has to be involved. That is the most important issue, rather than just giving the responsibility to someone. A health minister of state or center is only focusing on treatment centers. That's not healthcare. The finance department is important, the law department is important, education department is important, agriculture is important. All should sit together and discuss about removing the inequities. All ministers must be health ministers. That's how you have to move forward.
Yeah, multi-sectoral action, sir.
Yeah, thank you.
Thank you. Thank you. Dr. Rajgopal, over to you now.
Okay, ma'am. So once again, good evening, everyone. So on behalf of HEAL, Health Equity Action Learning Foundation, I extend my heartfelt gratitude to each one of you for joining us today as we celebrate the second Foundation Day through this insightful webinar on health equity. A sincere thanks goes to Professor Dr. Manmeet Kaur, who graciously moderated today's sessions. Thank you, ma'am. And special thanks are extended to our esteemed speakers, Dr. P.K. Shashidharan and Professor Rajesh Kumar, who shared their wealth of knowledge, enriching us with valuable insights that will undoubtedly contribute to our collective understanding of health equity challenges and solutions. A heartfelt acknowledgement is due to the dedicated team of field comprising of Dr. Guneet Singh SC, Dr. Inayat, Dr. Jasveer Kaur, Professor PVM Lakshmi, Dr. Abhishek Sharma, Mr. Vijin PP, whose commitment and collaborative efforts have been instrumental in making this webinar a reality. And a special note of thanks to all the participants who honored us with their presence, in spite of the technical issues that we have faced, contributing their time, expertise, and perspective to make this event a truly enriching experience. And thank you all, and let's be inspired by this webinar to continue our collective efforts towards a healthier and a more equitable world. Thank you once again, and we really hope to see you in our future endeavors of HEAL Foundation. Thank you all. And thus we conclude the first webinar on the series of 5 to 6 webinars to be followed, and hope you all join in our future webinars too. Thank you all.
Thank you. See you. Thank you.
Thank you, sir.
Thank you. Bye.
Thank you.
Thank you.
Technical hitch actually has disturbed us a bit, but good that we could start and we are progressing well.